Let me get going. Sarah, thank you for the introduction, and to the rest of the HLAA Northern California chapter officers for inviting me to talk here today. And yes, I am an audiologist. I've been in the Bay Area my entire career, and started at UCSF, moved into private practice, and then thought I wanted to go back into more of a hospital, university-based setting. But boy, I love the autonomy. So here I am back in Corte Madera at Marin Hearing Center, and I've been here since 2018. We have another office, a part of our group in San Francisco, that's called San Francisco Hearing Center. And so we have two offices, and that's probably all we're going to be growing to at this time and this point in our careers. Today, I want to talk about a topic that's getting more and more attention, and that is hearing loss and cognition. And is there a correlation? Some might have been reading reports, studies, documents, articles that are talking about this subject. Some make it very, very doom and gloom, like you have to do this yesterday. Others say there's no real correlation. There's no real evidence yet to support this movement. So I'm going to kind of shed some light on where we are currently in the literature, how we're doing it in practice, and what we should be thinking about as we are going forward here. Also, if there are any questions that people have after this presentation, if I don't answer them, feel free to contact the clinic here at the number that I've provided. I've left my email, my work email, and then that is our website below that, if you want to sort of look in and see what our office is all about. One of the interesting things about hearing loss and cognition, when you look specifically at hearing and cognition, and you look at how many studies have been done on this topic. If you look at it, if you did a literature search back in 2000 to 2002, over a 2-year period, you're going to find 31 citations showing hearing and cognition being involved in some way. From 2020 to 2022, these past 2 years, there's been over 450 research studies done on just hearing and cognition. So this is happening both within our field of audiology study, but also outside the field amongst our neurology group as well, and other neurophysiologists beginning to really look into this in greater detail. So the cases of hearing loss and dementia, why is there a correlation? Let's find out. We'll start with some statistics and facts. You can kind of read what's there, but really the take home to this is that the cases of cognitive decline, mild cognitive impairment, dementia, Alzheimer's are all on the increase. And it's kind of scary. But within the next 20 to 30 years, they're expecting that cases are going to double or triple over that time period. So this subject is receiving more and more attention from all aspects of medicine and in terms of how we are managing our overall brain health. So we want to look at this a little bit closer. And one of the things that was done was there was a Lancet commission group that met to further investigate this specific topic, dementia. Okay. And for those who aren't familiar, a Lancet commission group or a Lancet commission report is a very detailed, involved investigation into a particular topic or field of study in medicine. In this case, the Lancet report that was done in 2017 was a group of 25 different specialists in all aspects of medicine that met over a 2 to 3 year period of time to further investigate the literature, the studies, and how we could potentially better manage people with cognitive issues, dementia, or Alzheimer's, so that we can potentially change maybe public policy or even practice. The Lancet Commission also kind of found the same statistical analysis that, they expect in the next 20 to 30 years, a sharp rise in the number of cases. And we need to start looking into finding out why this is happening. The report was completed in 2017. They did an updated report in 2020. They tend to redo these every 2-3 years, but you can find and locate them online if you want to read them a little bit closer. The main takeaway from that Lancet Commission report was that they identified 12 modifiable risk factors that accounted for 40% of dementia cases. Okay, so when you look at dementia, we understand that some of this can be hereditary, but we're also really discovering that many cases of our overall brain health are the result of lifestyle, how we are managing things. So what is a modifiable risk factor? The definition of one is that it is a condition that just increases your risk for developing a potential disease. The good news, or the silver lining in a modifiable risk factor, is that you have control over potentially preventing them by making some lifestyle changes and shifts. Okay. Now, the 12 modifiable risk factors are listed here: hearing loss, childhood education, smoking, depression, physical inactivity, social isolation, traumatic brain injury, hypertension, air pollution, alcohol consumption, obesity, and diabetes. Please let me know if anybody wants to get a copy of these slides. I'm more than happy to email them to you. So just drop me an email if you want them, and I'll send them. I'll be happy to upload them and send them to you. So I tried to make the slides applicable to sort of follow. But these 12 modifiable risk factors were deemed to be that accounted for 40% of dementia cases. Now, hearing loss, each of these 12, hearing loss ranked as the highest percentage of the risk towards dementia. Now, hearing loss, I will say this, we're talking about untreated hearing loss. Okay, this is not hearing loss that's treated with hearing devices, and I will say that it should be treated with appropriately fitted hearing devices. And unfortunately, it doesn't matter what degree of hearing loss we're talking about. It could be mild, moderate, severe, profound, or any category thereof. The more significant the hearing loss, the more impact it can have on our brain health. But even for very mild degrees of hearing loss, it can have a significant shift on our overall cognition. So why does hearing loss rank so high? There were 3 basic reasons, and this is really the first explanation as to why the correlation that hearing loss has with dementia. Number 1 is that untreated hearing loss shifts the load of the brain. Basically, when you're spending more time processing what you hear, your brain has less bandwidth to deal with trying to think logically about what you're talking about, or even develop a memory to pull together to bring up a response. If you're replaying what you're hearing to a point that it's almost paralyzing your brain, this is one of those aspects. Untreated hearing loss also can accelerate brain atrophy. This one's hard to read, okay? Unfortunately, by the time we hit our mid to late 30s, we have peaked as a human being, and everything slowly begins to decline. So while all brains will shrink as we age, unfortunately, untreated hearing loss can accelerate that process. Finally, untreated hearing loss also can lead to isolation and loneliness. And when you start adding some of these other behavioral changes that occur, it significantly increases the risk for dementia. And in this case, isolation with hearing loss can increase our dementia risk by 50%. So hearing loss has these comorbidities, not a modifiable risk factor, but a comorbidity. There's 7 of them, but let's first define what a comorbidity is. A comorbidity is the simultaneous presence of 2 or more medical conditions that can contribute to the primary diagnosis. Okay, so we'll kind of go off script, not hearing loss, but we'll just say like somebody who is diagnosed with depression may be diagnosed with depression and an anxiety disorder. Anxiety is kind of a comorbidity to the diagnosis of depression. They can go together. Hearing loss has comorbidities that can significantly follow the diagnosis of untreated hearing loss. And if we are not paying attention to them as modifiable risk factors, they can become a more permanent behavioral change that's harder to reverse. So the comorbidities of hearing loss include social isolation, loneliness, depression, an increased risk for falls, cardiovascular disease, diabetes, and cognitive impairment or dementia. Now, this list has some similarities to the modifiable risk factors for dementia. So let's take a look at that. Kind of put them side by side. I've highlighted the ones that you'll see on each side of the list. And that is, on the left side of the screen, you're going to see modifiable risk factors for dementia. Hearing loss ranks as the highest percentage modifiable risk factor. Over on the right side of the screen, the screen for comorbidities of untreated hearing loss, you'll see that cognitive decline or dementia is listed as an association to untreated hearing loss. The longer the untreated hearing loss goes, the greater the risk of cognitive decline and the increased risk for dementia. This is the second correlation as to why hearing loss and cognition are closely related. So when I see my patients, I always say that we hear in the ear, but we're understanding in the brain. And hearing the ear is just a catalyst to get the information up here so it can be decoded into meaningful speech or sound. And even if we're indirectly not addressing the hearing issue, it is indirectly shifting how your brain is neurologically being wired to compensate for some of the deficiencies that are happening below the brainstem at the peripheral hearing level. And unfortunately, hearing is one of those slippery slopes, is that we don't always see personally as the individual person that we're having more difficulty hearing. It usually comes from other family members, friends, close relatives that are comfortable enough bringing it to our attention. And then we might continue to kind of carry along and say, well, is it me or is it the situation? Is it me or is the restaurant too loud? Is it me or are they talking too soft? Or is it me or are they mumbling? Until we kind of go in and get our first hearing screening and kind of find out. Sometimes a little both. So the concern is that the fact that some of these comorbidities, and I'll read this part because this was important to me, is that some of these risk factors has the potential to lead to many different conditions: social isolation, depression, falls, cardiovascular disease, diabetes, cognitive decline, and in this case, hearing loss. But each of these conditions in turn has the potential to cause or worsen another condition. This is sort of that slippery slope, the domino effect. If we don't treat one, we don't treat the diagnosis of hearing loss, these other ones in yellow are coming up behind, and it's going to be hard to hold them off without managing it. So now let me just back up for a moment and let's kind of connect the dots about our ear, our hearing, how it goes to the brain, and what's shifting in the brain, okay? So let's start with the peripheral hearing. You have a photo of the ear on the right side of the screen. The ear is broken up into three parts. The first part is the outer ear. The outer ear is your ear itself, the ear canal, and the eardrum. At that point, we then move into the middle ear. The middle ear is where the three smallest bones in our body live. The first one is the malleus. It attaches to the eardrum and it converts a sound wave from the ear canal to vibration. It's attached to the incus and then the stapes. They are the three smallest bones in the body, so if you want to remember that for a future trivia question, you got the answer. That's where they live. The eustachian tube is also in the middle ear. The eustachian tube is what we use to equalize pressure from elevation changes. The inner ear is where I'm going to spend a little more time. The inner ear is made up of two different parts, a hearing and a balance part. The hearing part is called the cochlea, and that's the snail shell. And the balance part is called the vestibular system, and that's where the three rings are present there. They share the same capsule, but they're really two separate structures, okay? We're going to focus on the cochlea, and inside the cochlea are two types of hair cells. You have outer hair cells and inner hair cells, all right? Now we're going to go to the next slide, and I'm going to take a cross section of this cochlea so you can see inside, and we're going to take a look at what the outer hair cells look like and the inner hair cells. And I like to analogous this to like a piano. So I kind of use this explanation with patients when I'm describing their hearing audiogram, hearing test results. So in the picture on your left is that cross section of the cochlea. You'll see one part that says outer hair cells, the other part that says inner hair cells. The outer hair cells, there are multiple layers of outer hair cells. Kind of equate that to the white notes of the piano because you have more of them. The inner hair cells, you have one row. Those would be the black keys on the piano because there's fewer of them. The outer hair cells respond to soft speech and comfortable speech. soft sounds, comfortable sounds. So if anybody is familiar with an audiogram, anything from 0 in sound down to about 60 to 70 dB in sound, okay? The inner hair cells are responding to loud speech or loud sounds, okay? Different tuning, because the brain has to deal with this in a different way. So anything from 70 dB and above, your inner hair cells are responding. Now, attached to each hair cell is a nerve fiber. And like a piano key, there's a string that attaches to it. So attached to each hair cell in the inner ear, whether it's an outer or an inner hair cell, is a nerve fiber. And when that frequency of that hair cell fires, it gives that nerve fiber a little coded piece of information. Not meaning, just a coded piece of information. And it takes the other hair cells, codes, and it moves this up to the nerve bundle, up to the brain to be processed and decoded into meaningful speech. So this is why I tell people we hear in our ear, but we are understanding in our brain. The ear is only giving us a Morse code of information. The brain has to make sense of it, all right? So let's go to the brain. So in this picture, you're looking at what is called the central auditory nervous system, or the CANS. And in the lower left of that photo, you'll see that little snail shell looking figure. That is the inner ear cochlea. And that little red arrow coming out of that is that nerve fiber meeting up with the nerve bundle. And once it moves out of the cochlea, we are now on the highway of the brainstem. Here, the neural information is moving up to the cortex. It stops off at different way stations. It literally is doing neural processing at different way stations on its way up to the cortex. The first stop is where it's localizing sound sources. So when we hear something and we don't see it, the brain tells us which direction we should turn. That's happening at the brain level. 2, it goes up further and stops off the next way station. This is where the brain is filtering noise to help us pull out speech in restaurants, family get-togethers. Multiple people are talking, but I'm trying to focus on this one, okay? This is the nerve's responsibility. Once it does that neural processing, it goes up to the next way station. And here it's adjusting for people who talk too quickly or have a dialect or accent that we can't understand as well, or are not familiar with, I should say. And the nerve flips some switches to help us better understand it. Then it goes to the cortex of our brain to help us now make sense of it, speech or a sound. If, however, the cortex doesn't have a clear message, then it's going to send it back down for further processing. Here, the nerve now has to fill in the missing sounds and words. And when the brain has to fill in the missing sounds and words too much, then it can become overwhelmed. This is where cognitive fatigue comes into play. We're using more energy to listen and understand than we have to. We're replaying what we heard was a cat or bat. And we're constantly having to do that with almost every sentence or every other sentence. And it's hard for us to keep, to stay with a particular conversation as a result. You may have experienced or have seen others when they're in a noisy environment and they're initially trying to work to kind of work through the noise, understand the speech the best they can, and then 15 minutes, 20 minutes, 30 minutes into the meal, you find that people are just kind of slowly checking out a little bit more and more. And that's because not because they're not interested. It is just because this part of the brain is just using more effort and energy to listen. And as a result, it's too tired and it needs a break. And so it's just taking some mental breaks to try to re-engage, except it gets harder and harder to re-engage. Okay. So when the auditory cortex finds that we're trying to fill in these missing sounds and words too much, this is where you get into this neuroplasticity, or what they call cortical resource allocation. The auditory cortex is asking other parts of the brain to help out. I need reinforcements. Okay. Now that sounds great, but the problem is when we are asking for cortical resource allocation shifts, it's using more, again, neural energy to do this. This next slide kind of talks about this cortical resource allocation. This is a 2020 study that was done that looked at cortical processing with auditory information that was presented to the ear, comparing it to a normal hearing ear versus an ear with hearing loss, and then that same ear after 6 months of hearing device use. But first, comparing it to normal hearing ear versus one with a hearing loss, they're using an evoked potential that they're able to measure, and then an MRI to sort of highlight it and see where the brain lights up. Where is it processing? On the left side of the screen, the picture where it says pre-hearing aid, that would be basically a normal hearing ear. I'm sorry, on the right side of the screen where it says 6 months post-hearing aid, that is what the normal hearing ear auditory processing should look like. It's lit up in the temporal lobe, it's in the auditory cortex, and it's doing all the neural processing in that area. Okay. On the left side of the screen, or the picture, the left side of the picture where it says pre-hearing aid, this is the hearing loss ear. You can see some of that auditory cortex is being accessed, but it's asking, here's other areas of the brain to help out. Here it's more the frontal cortex, the visual system, to help kind of use nonverbal cues, lip reading, whatever it can to kind of pull out anything else to confirm what they're actually hearing. Okay. So this is the magic of the brain. If we never had hearing devices or resources to help improve our residual hearing, this is necessary to continue to kind of forge our way through in this world. But doing this takes a toll. And as a result, in addition to it allocating to other areas of the brain, they found that overall global cognitive functioning, processing speed, working memory, all decreased compared to a normal hearing ear. It's like walking around with 10-pound weights as a normal hearing ear in a hearing and noise restaurant, and now you're carrying 50-pound weights, right? It's only a matter of time you put them down. So how are we going to loosen this cognitive load? The beautiful thing in this study is that after hearing device use, they measured 6 months post. You can see everything just moved back to that cortical area. All right. And in addition, they were also, those cortical domains that showed decline improved. So this just, again, this is the third reason why hearing loss and cognition have a correlation and have the interest of all sorts of brain experts out there, because it has such an impact on how our brain is organizing things. What we've done now and are starting to use more in our clinic is cognition screening. Screening tests, there's a lot of them out there. I've listed the majority of the more popular ones. They take about 5 to 15 minutes to complete. These are not diagnostic tests for cognition or for a diagnosis of dementia, but it does give us some indications of how the brain is currently processing. We use the first one, CogniView. This is a new type of computer-based program that looks at 5 factors: memory, visual spatial, executive functioning, reaction time, and processing speed. And what's interesting about these results is that it gives patients a better indication of where they are and how hearing loss can have a bit more of an impact on how their brain is using more effort and energy to listen. But after hearing device use and putting somebody back on the CogniView and re-measuring, a lot of times you see these scores bounce right back up to the normal range. And it's our objective way of determining whether somebody is in a modifiable risk factor for untreated hearing loss, and determining after hearing device use that we're back on track. Or if those scores are not coming back up, we probably need to get this person's over to their primary care physician and let them evaluate this further with maybe some additional specialized testing. Because we might be now down a road that's just too far where we can't reverse that effect. Okay. So cognition screenings are becoming more and more popular in diagnostic clinics, and rightfully so. Last slide, brain listening exercises. Brain listening exercises. This is another way to kind of keep the brain and the central auditory nervous system sharp and tuned. And we use this in our practice for those who come in for their 6-month wellness checks with hearing devices. Sometimes there's a program adjustment that needs to be done, but sometimes it's more about how the brain is currently processing, needs a little more help. These exercises are done to further enhance and sharpen those components within the central auditory nervous system. We really support and work with LACE, the top one, Listening and Communication Enhancement. This was a program developed out of UCSF by Chris Schreiner and his group, who's a neurophysiologist who developed Posit Science, but he had developed a specific offshoot that worked right within the auditory system called LACE. It works on hearing and noise, rapid speech exercises, multiple talkers, but you're focusing on a particular listener, filling in missing words, all things that can help sharpen that neural tract pathway. You'll see some of these others that I've listed. These are more phone app exercises. Amplify is probably the best of the other ones, but they all sort of have a role somewhere. But basically, it's just trying to help loosen the weight that you carry when times get challenging up in the executive functioning region. Hearing and noise, multiple talkers, rapid speech, dialects. These exercises just help to tune up that part of the brain. So I'll leave it to questions here, but I would just recommend here going forward for those who haven't or those you know should be getting a baseline hearing test. It should be part of a wellness check. Hopefully at some point in the very near future, we're starting to move in that direction. And any hearing loss, even if it's mild, there is no such thing as normal hearing loss for my age. it's normal for all of us to experience hearing loss, but it is not normal to not take action on it. So don't be confused with normal for your age for normal hearing, okay? Sometimes people feel that way. And once a month, I kind of find somebody, alluding to that comment, and we have to talk that through. But I'll leave it at that. Thank you. Any questions?
Okay, so it looks like that we lost Sarah again.
Yeah, it's pouring over here. I'm sure it is by everybody else, but we're lucky to have power right now too.
Yeah, because I see her husband's also gone.
Yeah.
So Janine seems to have a question. Let me spotlight her and she could unmute herself and go ahead, Janine.
Yeah. Can you hear me?
Yes.
1 second. Let me take this in. Okay. Thank you for your presentation. I have a few things I'd like to say. First of all, my father, he was working until he was 93 as a physician. He was extremely bright. He was a member of Mensa. He started losing his hearing in his 80s, but he was still working. He got a hearing aid. It wore them. Long story short, he still got dementia. That's first of all. The second thing I want to mention is basically you're saying if you treat hearing loss, meaning if you get a hearing aid or a cochlear implant that amplifies so that all the sound goes through to your brain and the brain doesn't waste as much energy processing it. Do I have that correct?
Yes.
My question is, what if the hearing loss can't be treated? I mean, it's not like a disease. You'll never get back the hearing. And if you take out the hearing aid, you won't hear. So you would have to wear it all the time. Have you ever heard of auditory processing disorder?
Yes.
Well, this is what happened to me. I wore a hearing aid for 20 something years, and maybe it's different today, but I have spoken to many people who wear hearing aids, different models and brands, and they've had the hearing aid adjusted, tried different kinds, and they still cannot understand people's speech. And that was my problem too.
Yeah.
I understand your point that the brain's working, using up energy, trying to process something. But you know what? I'm taking a shortcut. This is where, for people like me, we use captions. And I feel I'm still exercising my brain because I have to read the captions and I'm processing it because I'm not going to try to have different hearing aids and amplify. And my auditory nerve is impaired. It was damaged at birth by antibiotic, 50%. And also, there's no proof that when you get older, if you've had like diabetes or a heart problem, whatever, that those aren't the direct factors for dementia. I mean, I put a hearing aid in me, treat my hearing, and I'm fine. But something else will still happen. I'll still get dementia. So, you have studies that actually have shown for people like me with auditory processing disorder, which is really important for the brain to get things, that treating hearing loss with hearing aids really shows improvement.
Mm-hmm. Yeah, that's a good comment, Janine, in that an auditory processing disorder we're talking about something completely different than basically how this talk was designed. But not to dismiss it in any way. An auditory processing disorder or a brain is just wired a little bit differently wired a little bit differently at the central auditory nervous system level to handle speech and noise differently. Just as someone who is motion intolerant, when they get on a merry-go-round and it can turn into their worst day of their life because it makes them nauseous and sick, their system is wired to handle motion differently than the average person. Okay. So there were multiple factors that probably led to where you are today with an implant. And the fact that you need to allocate other resources to continue to enhance your comprehension and ease your brain of the cognitive load that it has to deal with on a daily basis is absolutely appropriate. Okay. The point is not to have the frontal cortex in control. But if you look at the average person with hearing loss, they are indirectly allocating other areas of the brain to do work that's not necessary. So in your case, it's just a little bit different in how those resources, they need to be allocated, but you need to, again, improve the speech to noise ratio as best you can and to have as many options to help verify what you're processing auditorily and visually so that it helps with comprehension. As for your father, identified at 80, was that his first baseline hearing test? Do you remember, or do you have a hearing test before that?
His exact age.
Right? And that's the thing is, like, when we're seeing people still, it's like
late 70s, 80s, something.
Yeah.
I'm not sure.
We begin to lose hearing on average, 1 dB a year beginning in our mid to late 30s. And the first couple of decades after that, the brain can make up those differences. It's the next 2 to 3 decades after that where it starts to change things. And yet, because it happens so slowly, we don't know that we're actually we're dealing with the hearing issue. And that's why it kind of catches people by surprise. If we're identifying somebody in their 60s or 70s with a hearing loss and they felt like a year or two ago their hearing was normal, there's just no way that's going to happen. It just, if it did, we call that a sudden hearing loss, and people will go to the emergency room first before they actually get to our office, right? And you would kind of experience that with some antibiotics, right? It was like, I had some hearing and now I'm dealing with a whole nother, aspect. So the sneak attack of hearing loss is kind of where I'm coming from this presentation. So I'm sorry it's not always as applicable to everybody, but I have some questions in the chat box. The comment is, I'm not sure the Lancet study took into account the demographics of the boomers and that we live longer in terms of the big increase in dementia. Just wonder if the per person risk is greatly increased. This relationship between cognition and hearing seems so important to me that it ought to be standard practice for audiologists, but it's not at Kaiser, I know, nor at Costco, the audiologist likely, nor at Costco, and audiologists are likely to not to do it. How rare is it? Where is it standard practice in the East Bay where you don't have a clinic? Could you please stop screen sharing? Yes, I can. Hopefully I can do this well. Did I stop screen sharing? Can somebody confirm that for me?
Yes, you did.
Okay, good. And then I'll pull that chat. Hopefully, do I still have the chat option open? Maybe I lost that because I'm now not a co-host. But to answer that, cognitive screeners are becoming more and more a part of offices than they've been in the past. It's still a slow roll. I mean, we're still human beings and we're audiologists and we're creatures of habit, and it's hard for us to change, just as any other human being is hard to change. So incorporating this into diagnostic practice is slow to sort of evolve. The Costco's and the Kaisers, at some point, hopefully we start to see that. I'm sure at UCSF this is happening, but you're starting to see more and more offices using it. We believe in it. We believe in the science. When we practice here, we are practicing as if this is a medical issue rather than it is an elective, because there's just too much evidence to support that. And I don't think the studies have longitudinally gone long enough to help us better understand these behavioral aspects that can contribute to dementia and cognitive decline. So that's why more and more of these studies are happening, and we're looking at them in different directions so that we can be better diagnosticians and preventative as well along the way. Any other questions?
Yes.
Please.
Can you hear me?
I can, Alan.
Okay, thank you.
Yes.
Yes, it's very interesting about using brain.
Sorry, Alan.
Alan, you're muted. Please unmute yourself.
Okay, can you hear me now?
Yeah, start over.
Oh, okay. It's very interesting about how you're using your, I guess, brain energy to strain yourself to understand or hear things. This seems to be in sync with what Alzheimer's researchers have been preaching for a few years now, is to avoid eating for 12 hours a day. Basically, you could do that from, say, 6 to 6 while you sleep.
Yep.
It gives the brain, according to these researchers, it gives the brain a chance to recover from processing sugar. Do you have any comments on that?
Sure. I tell patients as well, this is one of my other elevator speeches I kind of go through with them, is that your brain and body don't care where the energy is coming from. You get a certain amount when you wake up every day. And if you slept well, you kept up on hydration and exercise, and your nutrition is good, etc., you might wake up with a little more than usual. You're on your game, right? You know when you're on a good day. And then there's other days where it's like, I woke up and I'm not feeling like I've got everything going for me today. And you're probably going to find that if there's some untreated hearing loss, you're going to struggle a little bit more that day with your hearing than on days when you have more energy. Because the undertow of untreated hearing loss is just that. You are actively listening. It is an exercise. You are using your brain to work. And as a result, it is costing you some pennies later in the day. For example, and Alan, tell me if this is applicable to what you're talking about with Alzheimer's research, because when your stomach has to digest more frequently from frequent meals, then it makes perfect sense. You're going to get more tired. Okay. And until the internal organs do their work and you can kind of give a little time to recover, then you can feel like you can do another activity. And I say this as well as like, if you have a hearing issue and you're at a restaurant and you're eating your meal and now your stomach's kind of full, you're not the one who's going to ask for the dessert menu or coffee and extend the evening, right? You're ready to like, I'm ready to go to bed. I'm ready to just shut down because the cognitive energy of listening and now your body digesting food is just way overwhelming. Okay. So the mental energy is just as significant as the physical. It doesn't mean you don't exercise. You have to still, have the body do the proper flexibility and mobility and strength training to keep ourselves active and fit. Because when we're doing less, that's where the risk for falls and the cardiovascular disease increases. It's just a kind of a domino effect, if you will. That's why those comorbidities are listed that way. All right. Does that answer your question, Alan?
Thank you.
Hi
Yes.
there. Before we go on, I would like to say I'm Tana Cooley. I'm Vice President of HLA North Bay. Sarah, who started the meeting, our president, has lost internet. So I am kind of stepping in to moderate the rest of the meeting and close it down. We technically end this meeting at 5 o'clock. We are now at 5:05. So I wanted to check with Andrew, since I didn't make the arrangements, on whether or not you're available to stick around for questions, or if you have another commitment.
I am available until about 5:15, 5:30. I'm on pickup duty, so for my son. Sorry.
Okay, that's good.
Yeah.
Before we go to another question, I do need to make the announcement that our chapter has a meeting, not next Thursday, but the Thursday after that, called Hope, which is hearing other people's experiences at the same time. And you're all welcome to join. I think Sarah did the other announcements. I missed them. But Andrew, if you're willing, that means we have maybe 10 more minutes to go through questions, and
Absolutely.
then we'll end the meeting at 5:15. Alan, I think you've had some questions, and there's another hand up, and maybe we can come back to you, Alan. 2 more hands up. So
No,
Susan's
I'm good.
Susan's hand went up first. So Susan, if you can unmute yourself and ask your question, that would be great.
Hi. Just a quick question. I got my first hearing aid 10 minutes before the pandemic, which means that I really never got a follow-up appointment to fine-tune it.
Oh.
I have not bonded with this hearing aid as a consequence. I hate it. I can't wait for a new one.
Yeah.
But my question would be whether I ought to give it another chance, or if I really can, feel free to move on. That's what I want to do.
Yeah. Good question, Susan. We did have some of those pandemic fittings too. And about 6 weeks after everything shut down, we called those fittings back in so we could do a more proper program setting, than out of the box kind of setting. So let me reference it this way first. Any hearing device that I fit on an individual has to fit 4 standards or pillars in order for it to be a successful fit. Number 1, the hearing device needs to be physically comfortable in or on your ear. You've got to forget that it's there. 2, it has to sound natural. And this is kind of foreign, and this is kind of the one, it looks like the one that's bothering you. The naturalness of that sound is that it has to match how your brain wants to hear sound with your hearing loss, because each hearing loss is an individual loss. How you hear sound with your hearing loss is different than somebody else who hears it with their hearing loss. That's why this profession is a science to it, but there's also an art to it. So the sound of your device needs to be natural. Each manufacturer amplifies sound, but how they do that is what makes them proprietary. And if it's not the right match for you, then it's not the right device. The third thing your hearing device needs to do is work. It has to perform. It has to improve in the areas you wanted to see improvements. And if it's not, then you need to have a discussion with your provider. And 4, it needs to be aesthetically pleasing so that you're comfortable and confident wearing it. Okay. If any one of these 4 are not being met when I'm working with somebody, we're having another discussion, because it's not the right device, or we have to talk about the compromises of why we're not able to achieve that standard. Okay. So I would go back and talk to them about it, and they can redo the real ear, look at your program settings, look at your fitting, talk about what's working, what's not working, so that it can be a better match. Because if you're not bonding with it, then who would wear it? Okay. It has to work for you and your lifestyle. Okay.
I do wear it because I'm terrified of dementia.
Yes, I know. That's why people come in. I know. It's like, oh, I'll do anything, but we don't
Okay,
need you to
have
like.
about 5 more minutes, and Virginia had her hand up. Would you like to unmute yourself? Remember, we only have about 5 minutes for question and answer. And I see, Alan, your hand is up, but I want to give people a chance. Oh,
my hand was up
it
to
looked like
get.
it. Okay, so Virginia, would you like to ask your question?
Am I unmuted? Can you hear me?
I can.
You can.
Yes.
This is not about hearing because I hear, it's about my ears and my brain. For many years, and Tana knows who I am. I've looked everywhere and keep asking the same questions, hoping I've never even run into somebody else that has the same problem I had. Now, I can't be that unique. I can't be unique, but I can hear, but it feels like I'm like there's my ears feel like they're stuffed all the time. And so this pressure, it's feeling a pressure in my ears. And this constant pressure makes me feel like I would like to scream especially when I talk or I try to concentrate on something. I feel like I'm trying to press through my brain to get to my brain.
Yeah.
That's the best way I could describe it, but it's so exhausting.
Yeah.
Give me any idea of what's going on or where I could get help.
You got it. Are you wearing hearing devices, Virginia?
No.
No.
And I live in a retirement home, and everybody has hearing aids, and everybody says, I can't hear, and I can't hear, and I can hear everybody. I'm interpreting for everybody else.
Yeah. Have you gotten your hearing screening yet?
Yes, a number of times.
Yeah. And hearing is perfectly normal?
Yes.
Okay. If you are dealing with something like that, where your ears feel plugged or stuffed, and your hearing is perfectly normal, then we maybe be dealing with 2 different things. Number 1, I would probably recommend you go see an ear, nose, and throat physician first.
I've done it all. I've done all the
And they've ruled out any medical issue.
Yes. I've seen all the people at Kaiser, and then I've gone outside of Kaiser to other private doctors, ENT doctors, and I did see one who had was interested and tried to think of what else that he could do for me or where we could explore, but it just led to nothing.
Yeah.
And also, you could hear my voice.
Yeah.
The right side of my throat hurts, and after I talk a little bit, then I can't talk anymore. It just gets so scratchy.
Yeah. The other concern you have is that when you're in noise, it's more difficult to understand. It's hard for you to pull out the voice when the pressure in your ears is increased like that.
Yeah. And people complain, they say, I can't understand you, especially on the phone. So altogether, It's just
They
so,
can't understand you or you can't understand them.
oh, well, actually both ways. They can't understand me because my voice is,
Okay.
but sometimes on the phone, that's an interesting thing. Face to face, I can hear, but over the phone, sometimes I can't hear too well. I don't know whether it's the other party or me, but I'll say I can't understand what you're saying.
Yeah. I'm under the assumption that your hearing is perfectly normal. Again, sometimes people's interpretation of that might be different. Without really seeing that, it's hard for me to kind of comment on those so specifically. But if you would like to come in for a consultation or have a copy of your hearing test with you, I'm happy to discuss that further if I can see something. And then we can talk about those symptoms further. So
Where are you? I just know your
in
name.
Corte Madera.
In Corte Madera. Okay.
Yeah, in Corte Madera.
Okay, thank you.
Mhm.
Okay, thank you. I'm glad that you were able to talk about that and connect, and I wish you the best. It is now 5:15. I'm really thankful to Dr. Vala for coming and making such an excellent presentation. I hope you've seen some comments in the chat who really appreciated how well you did and what an important topic this is. And I'm grateful to all of you who came. I hope that we will see you again in some of our meetings. We have a variety of speakers, and every month we do have the support group. So with that, I would like to say, hope you all have a nice evening and hope to see you again. Take care.
Thanks.
Thank you,
Thanks,
Dr. Vala.
everybody.
Bye-bye.
Bye-bye.